and welcome to. I always start too early. So, again, hello everyone. Welcome to another weekly recap session. We have a great discussion incoming. And before, yes, I think it's now time for Monday, and I would like to start before rambling too much. So, for Monday's case, we had an amazing infectious disease VMR together with Dr. Lila Wood-Colburn, and I learned so much during this case discussion and would like to give you a brief problem representation. So we had a 53-year-old male presenting with acute onset of shortness of breath, fever, and diarrhea, and he was also presenting with multiple cysts in the liver, and it came out to be an invasive Klebsiella pneumonia infection. And for this, I made 2 teaching points. And for this, I would also like to share my screen. So my first teaching point is about giving you some insight about the radiographic imaging of hepatic abscesses. So I really like the teaching point of Dr. Lila when mentioning, so if you approach hepatic abscesses, if it's singular, always think of amoeba until proven otherwise. And if it's multiple hepatic abscesses, think of bacterial infections, especially gram-negative rods like E. coli, Klebsiella, but also anaerobes, staph strep, less likely, but yeah. And here's one sign that is called double target sign in CT with contrast. And there, an abscess looks like this, that you have a purulent fluid which is looking hypodense. And then we see some hyperdensity, which is the pyogenic or abscess membrane. And then again, we see this hypodense area, which is the edema. So this is one sign how hepatic abscesses can look like. And another sign is the cluster sign, where you have multiple small liver abscesses, which is indicative for pyogenic hepatic abscesses. And my third teaching point is about the mentioned positive string test. So for Klebsiella, it has several virulence factors, and there's one virulence factor that is associated with its hypermucoviscosity phenotype, and this phenotype is associated to metastasize and cause several infections like meningitis and endophthalmitis, so CNS infection, and also other abscesses in the lung. And in order to detect this one, there is this positive string test. So when you have this blood agar and you have a loop, and if you see a vicious rope that is greater than 5 millimeters, this is called a positive string test, as you can see. And so there is an association of hypervirulent Klebsiella strains and this phenotype, but it's not very sensitive, as I learned. And another fun fact that was also mentioned is this jelly red sputum of Klebsiella. So I made here these 2 pictures that you can see how it looks like. So basically jelly-like hemoptysis. Yeah, that's everything. And I have some questions for you, Ravi. The first question was actually that I had, wait, I stopped the sharing. So my first question was, we saw these pulmonary nodules, and I really have to say, I don't really have a great approach to it. And it was mentioned that it was a septic embolus. So can you say when it is, how you can say that it's a septic embolus? Yeah, I really don't know.
I think that's a fantastic question, and one that is layered on some incredible teaching, honestly. But I think if you ask yourself, how could you have suspected Klebsiella in this case? I think you zeroed in on the imaging that it's a liver abscess by the radiographic features that you just taught us. And then you taught us that if it's multiple, which this patient has, it's probably gram-negative rod. And the question is, how do you prioritize amongst all these gram-negative rods the presence of Klebsiella? And I think you had 2 clues. One is that the patient is diabetic. They didn't have a medical history of diabetes, but if you look at the glucose on the whiteboard, it was pretty elevated. It was in the almost 200s. But the other clue is what you just brought up, Shema. So when you think of gram-negative rods, you think of their origin being usually a GI source. So in this case, when you have liver and lung, you're saying, wait, hold on, it's not the usual GI sources I'm used to. And that's where the imaging characteristics that you pointed out are very helpful. So what are nodules? When there's one or a few nodules, it's a separate schema. But when you have multiple nodules, you have to zero in and zoom in on the microstructure of the lung. And the microstructure is an alveolus, a blood vessel, and the actual lymphatics that drain it. So when radiologists look at a nodule, they say, is it centralobular, which means it's in the middle in the airway? Is it perilymphatic in the lymph node area? Or is it hematogenous in the vessel? So CT has gotten so good that it can see if the nodule is mostly in the airway, mostly in the vessel, or mostly in the lymphatics. And you'll see on the website, there's a schema of nodules is centralobular equals airway, hematogenous equals vessel, and lymphatic. And when they zoom in, they see that in this case, it's actually hematogenous dissemination. So they see that there is a nodule in a vessel. And that that's the definition of a septic emboli, is there is an infection in a vessel. So that's how you can make the inference that this nodule, which is located in a hematogenous distribution in a patient who has an infection, is septic emboli. And that is a very powerful clue that Klebsiella is at play, because it is one of a few infections that has hematogenous dissemination to the liver and to the lung. Great question.
Awesome. And my second question would be, it was also mentioned by Dr. Laila that also people with asplenia are prone to Klebsiella infections because it has this capsula. And my question is, can you give us an insight of why asplenia and encapsulated bugs are always so dangerous? So the mechanism actually, because it was never explained to me before.
So, the mechanism is actually really interesting because it overlaps both infection and autoimmunity. When patients have autoimmune hemolytic anemia, a splenectomy is a cure. And when patients have disseminated capsule-producing organisms, splenectomy is deadly. Those are related to the same concept. And the concept is macrophages in the spleen, splenic macrophages, are specialized at being able to use antibodies attached to the surface of a specific polysaccharide structure and remove them. And so when there is no spleen, the macrophages lose the ability to remove these specific organisms with this specific polysaccharide. And when the spleen is too strong and too much, producing too many antibodies, these same macrophages remove accidentally red blood cells. So it all comes down to the phagocytic properties of the splenic macrophages, which are very avid towards certain polysaccharide structures, which exist in red blood cells in autoimmune hemolytic anemia, removing too many of them. And when removed, allow these phagocytic, polysaccharide capsule organisms to thrive. Same concept, which is really, really cool. Yeah, really.
Thank you so much.
Oh, of course. Thank you for the great recap and the great questions. All right, Ariel, let's jump into Tuesday.
All right, so this one is a little bit challenging for me because it's not a veterinary disease. It's the first time I ever learned about it. So I got some help from Rafa. But to recap, the case is a 74-year-old man with a past medical history of normocytic anemia, constitutional symptoms like weight loss and fatigue, and complain about joint pain for 18 months. We learned that the joint pain was bilateral in shoulders and hips and gradually progressive to proximal lower limbs. And on blood work, the most striking finding is the elevated ESR and CRP. And it's a relatively straightforward case. The patient has extracranial giant GCA manifest with polymyalgia rheumatica. And I was like struggling, was like, what's the clinical feature of this case? Like, why are we talking about it? So I reached out to Rafa and I was like, hey, what made you think this is a good case to present on VMR? And he has been so helpful, just demonstrating to like the community here. And he replied to me that there are two things that caught his eye. First is that giant cell arthritis can be commonly associated with polymyalgia rheumatica, and it can present with bilateral hip and shoulder pain with, morning stiffness is a prominent feature, raised inflammatory markers and constitutional symptoms. And second one is, unlike classic giant cell arthritis, large vessel giant cell arthritis usually don't have cranial symptoms like visual disturbance, jaw claudication, headache, temporal artery, scalp tenderness, anything like that, which our patient doesn't have. And a prior history of PMR is more common in large vessel GCA than cranial GCA. And he reminds us that PMR with atypical features of predominant lower limb pain, predominant lower back pain, refractory to moderate doses of steroids, or severe systematic symptoms should alert clinicians suspicion of large cell GCA. So after this interaction with Rafa, I still have questions related to this case, and I hope you can answer that. So this patient, because he declined the temporal artery biopsy, the diagnosis was made on base of the elevated ESR and the inflammatory markers. And he was responding to steroid treatment. But then I read that even if he only has PMR, he's very likely to have elevated inflammatory markers anyway. So I was like, how did we know that he has GCA in the first place?
Oh gosh, I have no idea. That case was really, really tricky. It really was. And I think what you had was somebody who had long-standing, over a year, of symptoms of shoulder pain and hip pain. And I think if you just start there and you ask yourself, what does that fundamentally mean? I think you should be confused. You should be very confused with a case like this. And I think your confusion is actually the most powerful teaching you can do, because PMR and GCA are some of the most challenging diagnoses we make. And only when we have the only way you can sleep at night knowing your patient has these things is when you have a biopsy showing it. But that situation is very rare. So I want you honestly to bottle that angst and concern and confusion and lack of clarity as fundamentally representing the complexity and the inherent challenges in diagnosing PMR specifically. What's your clue? In the best case scenario, your clue is the unusual feature that a patient has simultaneous shoulder pain on both sides. Most patients, when they have shoulder pain from some injury, which is usually a common cause, or some infection or some crystalline like gout, pseudogout, septic arthritis, or rotator cuff, it's only one shoulder. So the classic story of PMR is somebody wakes up and all of a sudden both shoulders hurt at the same time. And the other unusual feature is that they hurt so much in the morning, and then when you use them and loosen them up, they're better. So that's the classic story. But patient is a great reminder that patients can present unusually. This patient tolerated this discomfort for over a year before coming to care. And so whenever you're wondering a patient has polymyalgia rheumatica, again, you go back. The classic presentation is simultaneous bilateral shoulder and hip pain in both sides at the same time, no difference between the two, and that it gets better during the day, which is weird. But then how does giant cell arteritis come into this conversation? It comes into it because it's the most morbid. If you have PMR that's not treated, it doesn't matter for your life, because you will just be miserable physically with a lot of morbidity, but your life is not at risk. GCA comes in the conversation because it can be life-threatening and sight-threatening, meaning that it can cause some devastating chest problems and it can cause you to be blind. So that's why people worry about it. How often does it happen? About 20% of patients with PMR develop GCA, 20%, 1 in 5 chance. Most patients who have giant cell arteritis have had PMR in the past. So GCA is very, very, very small. Most of those people have had PMR, but only 20% of patients with PMR, which is a big circle, have GCA. So if you think about it, PMR is a massive circle and GCA is a tiny little corner. So whenever somebody has long-standing untreated PMR for a year, you have to wait, hold on. They're at the highest risk of getting GCA because I haven't treated them for a whole year. And then how you diagnose giant cell arteritis in those patients is a whole other conversation. I'm not sure that patient had giant cell arteritis. I'm not sure. The only way you would know is if you get a biopsy or if you did a CT that showed a vasculitis. So what can you take away from this case? I think exactly what we said, Ariel. Diagnosing giant cell arteritis is very hard, as is diagnosing PMR. The only way you know for sure is if you have a biopsy or if you have chest imaging showing vasculitis. Short of that, it's just a measure of how much risk you're willing to take. And some people, you say they have an untreated PMR for a whole year, they're at risk for GCA. I don't have the ability to confirm the diagnosis because of patient preference or resource limitation. So I'm just going to assume the worst case scenario and treat them for GCA. It's totally reasonable. And I think that's what happened in this case. Yeah.
Thank you. That makes
Does that answer your question?
Yes, it does.
A practical takeaway is bilateral simultaneous shoulder pain is very unusual. And then when you add in bilateral simultaneous shoulder pain that is worse in the morning and improves with exertion, that gets you PMR. And the rest, good luck to all of us to figuring it out. It's a tough one. All right, round 3. Marcella, tell us about Wednesday.
Yeah, hello everyone. So for this VMR, we had staff presenting and discussing 2 amazing cases. And for me, what was like the most important in those sessions was like how those cases were great to highlight situations when a careful and detailed physical exam can be very helpful for your differential diagnosis. So I'm going to talk about the 2 cases. The first case was a 32-year-old man with no significant past medical history. He used to work as a carpenter, presenting with an acute onset of left knee pain and swelling, limited range of motion. He denied any similar episodes, and he denied any trauma. And so at this point, we started discussing about the differential diagnosis of monoarthritis in the chat, until we saw the photos of the physical exam, and we noticed that the inflammation was not really in the intra-articular space, but it seems to be outside on the surrounding soft tissue. So especially localizing to the prepatellar region. And the final diagnosis was a prepatellar bursitis. And this detailed physical exam allowed us to make the diagnosis without further imaging or invasive tests, and that's wonderful. So my main teaching point here is when you see a case of knee pain, before you jump into the differential diagnosis of arthralgia, monoarthralgia, or monoarthritis, you should really try to differentiate in a detailed physical exam whether is it affecting the intra-articular space or is it something else. So in this case, for example, for the knee, you need to consider broad. So think about the anatomy. Could it be the bone, the muscle, ligaments, the bursa, or the other tissues around? And for this case, I have one question, Habi. So we consider mainly an infection as a differential diagnosis, but I was wondering what else would you be concerned about, like any autoimmune or other pathology that could present as a prepatellar bursitis or in the surrounding tissue?
That's such a great question, Marcel. And I love the point that you're making before that is to even suspect bursitis before diagnosing arthritis. And the truth is, understanding what the bursa is will help you generate your differential diagnosis. And the bursa is just the same fluid in the bursa as in the synovium. And so the differential diagnosis for an arthritis is the exact same differential diagnosis for bursitis. And the most common cause is septic, crystalline bursitis, but there's one thing that affects a bursa that doesn't affect the joint. And that additional diagnosis is trauma or irritation. You can't rub and irritate a joint, but you can rub and irritate a bursa. Unfortunately, it's very hard to diagnose traumatic bursitis with confidence, without ruling out infection. So even if you think it's trauma, most people end up getting antibiotics because you can't disprove that hypothesis. So a bursa is just a superficial synovial space with the exact same differential diagnosis. We add in trauma, but unfortunately, we don't act upon that because it's hard to rule out infection. It's a really good question.
Oh, thank you so much. Yeah, I was exactly wondering about that because for step 1, we usually study about like handmade knee and things like that. And I was like, oh, but it could be an infection. So how to do that, right? For the second case, we had a 42-year-old male with some chronic progressive dyspnea. Then we started thinking about the differential diagnosis, like is it the lung, the heart, anemia, or other DDX? But the main point here was like the physical exam clues for this differential diagnosis of dyspnea, because in this case, we had some signs pointing to heart failure as this origin for the dyspnea. And the two signs here was the high jugular venous pressure, but also the high venous pulsation that we could see very clear, and the respiratory pattern. So we had Cheyne-Stokes respiration. It's associated with severe heart failure. And what is it? So Cheyne-Stokes is a breathing disorder that is characterized by some alternating episodes of apnea and hyperventilation. So it happens because we have an unstable central respiratory control, mainly due to some changes in the apnea threshold and the fluctuating PCO2 levels in these patients with heart failure, stroke, or patients that are at risk of an unstable central respiratory control. And I have some links here for you. I was not sure if we were able to have enough time to present, but I'm going to send the links in the chat, just like to highlight the differences between the carotid pulse and the venous pulse. So as I learned in the chat, the carotid pulse, besides the anatomy, but it can be confusing, you have like, it's almost like the artery is popping. So you can see it popping. For the vein, you have it kind of collapsing, going down. So it's a subtle difference. And I would love if Javi has some like clues for us to differentiate, because it was a question in the chat. And also, Javi, I would love you to talk for us, like you are a ER doctor, you work in the ER too. And like when you see a patient with dyspnea, what are you like your first thoughts to look in the physical exam to try to help you guiding that?
Oh, Marcella, I think that's a superb question. Honestly, I think that the real advice about these exam signings is you just have to see them over and over and over again. So my only real advice is don't forget that you need to see normal to help you see abnormal. And I think we run towards the bedside of a patient who has shortness of breath to look at their JVP. But I think it's actually probably very helpful for you to go see somebody with toe pain who has a JVP, because seeing what normal fluctuations are like will allow you to detect when it's more abnormal. So if you can spot a JVP in a normal patient without hypervolemia, it'll be easier to spot a JVP in a patient with heart failure. So my advice is, just like you listen to patients' hearts who don't have any cardiac issues for the practice and to know what baseline is, do the same for the neck veins. It'll help you a lot. In terms of the initial evaluation of somebody with short of breath is very fascinating. And I think it's anytime that somebody says the word shortness of breath, you know that they're going to be with you for at least 2 hours, because you need to get some blood work and you need to get EKG and you need to get X-ray, and that at least takes 2 hours. So the question is, well, why do you need to spend a lot of time in the history? What's the point? If you're going to get all these very advanced tests, like a BNP, a chest X-ray, EKG, why history? And I will tell you that there's a truth to that. You don't have to be so thorough in your history when you're getting tests that objectively outperform your history in terms of their predictive value. If somebody says, no, I don't have orthopnea, but their BNP is 5,000, what are you going to believe, right? So the history is limited in patients with conditions that require a very advanced workup. Primary headache versus secondary headache doesn't matter if you're going to get an MRI. The MRI is way better than your history. So you have to acknowledge that. So my history is different in a patient with shortness of breath for whom I'm getting an extensive workup. And I just try to do three things. Is it swollen dyspnea? Is it inflammatory dyspnea? Or is it presyncopal dyspnea? When somebody has shortness of breath and they're swollen, it's almost always heart failure. Or somebody has dyspnea and they're inflamed, it's almost always pneumonia. And when somebody has dyspnea and they feel lightheaded, it's almost always cardiac. So I try to gauge those things to make progress on that. Ravi's making a really important caveat, and I think that in patients who are I assume that you have time in this situation. In patients who are critically ill, I think that in those situations, you're probably using response to therapy as a diagnostic test, and your physical exam is incredibly powerful in those situations. And as Ravi is teaching us more and more, I think a POCUS has a powerful role to play in the hyperacute severe shortness of breath scenario. Absolutely amazing questions, Marcel. Thank you. Focus equals love. Ravi, anything to add or any tips to share about that scenario?
Oh, sorry, were you asking me?
Yeah, I'm just
Oh,
curious.
sorry.
Yeah.
Oh, about the patient with congestive heart failure?
Oh, no, just to expand on your point when you're saying that when somebody is so sick that they are called into a rapid, how that changes for you.
Oh, yes, Deborah, I'm Amita. Yeah. Yeah, POCUS is incredibly powerful. I just going through this reminded me to a rapid where I actually had two medical students with me, and where we were called for a patient that was acutely decompensating. She had come in for some other issue, and we were waiting for x-rays, labs, and everything, but then she looked like she was decompensating. And just using the ultrasound, we were able to see the first POCUS VMR B lines. So looking at her original x-ray clear, now she had B lines. We looked at her previous echo history and she had LVH. We were like, okay, this looks, smells, walks, talks like congestive heart failure. So we gave Lasix, and just like you had mentioned, it was both therapeutic and diagnostic. She rapidly came off we had to put her on BiPAP. She rapidly came off of it, and we averted a disaster.
That's incredible. What a powerful way to make that emphatic point. I'll tell you about Thursday's case, and Thursday's case was just bamboozling. It involved a young female patient who presented with lower abdominal pain and diarrhea. And Marcel and I were in a very tense situation because we had two symptoms to figure out. Do we focus on the abdominal pain or do we focus on the diarrhea? And I'll let you try to figure out what you would do, because the answer will tell you what I think you should do. And so that patient, because of the abdominal pain, got a CT scan. And the CT scan showed nothing but some small bowel signal. And Marcella aptly said, you know what, let's focus on the small bowel. There's small bowel thickening. What can do that? And we thought long and hard about what the small bowel thickening and what the differential means, but it doesn't matter because the patient was discharged and came back feeling worse. And when the patient feels worse, you just repeat where you started, and she had a CT scan. And the CT scan was a game changer. It showed the interval development of ascites and interval development of peritoneal thickening and enhancement. And so initially, the case was very, very unclear. It was hard to know what to follow, but you can see how the case coalesced to a very clear problem representation. And the problem representation was a young woman with acute to subacute peritonitis. It was a much easier problem to solve than diarrhea, abdominal pain, whatnot. And so the answer became very obvious. Should we have been focusing on the diarrhea or should we have been focusing on the abdominal pain? And for sure, the abdominal pain was way more powerful lead. And it just goes to show you that all you really need to do is remember your own circumstances. All of you have had diarrhea at some point, and none of you had tremendous pain. If you did, then you had something else going on. So in the situation where you have something else in diarrhea, usually the diarrhea is a distractor and the something else is more important. And the vast majority of patients for whom the diarrhea is the important thing usually have nothing else going on except maybe some dehydration. That's key point number one. And number two is, how do you think about peritonitis? This patient had peritonitis. One, you know peritonitis exists in two specific contexts. When patients have cirrhosis and they get peritonitis, that's called spontaneous bacterial peritonitis. When patients have a peritoneal dialysis catheter and they get peritonitis, that's called peritoneal dialysis related peritonitis. So peritonitis in a very specific context, two of them, cirrhosis and peritoneal catheter. But what if you get peritonitis and you don't have any of those things? Then it's usually something that came from the GI tract, the GU tract, or the gynecological tract. So you have to ask yourself, this person has something in their peritoneum and it didn't come from cirrhosis and it didn't come from a catheter. Where did it come from? It probably came from the GI tract. It probably came from the GYN tract or the GU tract. And so I think in this patient, it was very, very humbling when we got the whopping result that her peritoneal cultures grew gonorrhea, Neisseria gonorrhea, which just like my jaw was on the floor. And it was a humble reminder that even though the patient had small bowel thickening, the source of her peritonitis was actually gynecological from pelvic inflammatory disease. So how can we reconcile that? How can we say the patient had a gynecological source of peritonitis yet had small bowel thickening? And remember that the small bowel can be thickened because of something inherently wrong with it, which is usually one of the 4 I's: infection, inflammation, ischemia, or infiltration. But sometimes can be because of external inflammation affecting the small bowel. The small bowel is constantly rubbing against the peritoneum, and if the peritoneum is inflamed, it's very easy to see how the small bowel won't enjoy that too. So what did this case teach us? I think it taught us to prioritize pain over diarrhea, and it taught us that in patients with peritonitis who get it without a clear source, either cirrhosis or peritonitis, you just have to go back to thinking very simply about where bacteria live in the abdomen normally. And they normally live in the bowel, they normally live in the bladder, and they normally live in the pelvis. And sometimes those things can ascend and go into the peritoneum. Very, very humbling reminder. Any questions about any of that? Yeah, a lot of chin and lip scratching. I could see it was very, very, very intriguing. All right, Mukund, the mic is yours for the Friday hurrah.
Sure, we'll do Friday. This was a really, really interesting case. This is a 35-year-old woman with worsening joint pain in the ankles and the small bones of the hands and the wrists. On physical exam, they found bibasilar crackles in the lungs. They found red and purple nodules in the skin along the shins, and they found elevated liver enzymes. So the final diagnosis was sarcoidosis, and she did respond to treatment with corticosteroids. But there are a couple of things in this case that may or may not be directly related to sarcoidosis that I found really fascinating. So we're going to go over them. Starting with an element of this person's past medical history, which is that she has seronegative rheumatoid arthritis. So as a reminder, the classic way to diagnose RA is by the presence of rheumatoid factor and anti-citrulline cyclic peptides, anti-CCP antibodies. But there are a good percentage of people who have RA who don't have either of these antibodies. A good percentage of them will later develop those antibodies, will turn seropositive. And a small percentage of them, according to a couple of interesting reviews I found out there, actually are misdiagnosed and end up having a seronegative spondyloarthropathy instead. But the majority of these people will never actually develop antibodies. And so you have to make a clinical diagnosis, which can be quite challenging and which requires pretty consistent follow-up over time. You try and do this by looking at the presence of symmetric inflammatory polyarthritis and other features of RA, the rheumatoid nodules in the skin, so on and so forth. But there's a really interesting genetic component to this, in which the same HLA alleles which predispose to seronegative RA are very closely overlapped with those that predispose to sarcoidosis, namely the HLA DRB1 allele. So that was a cool finding that came from the past medical history that wasn't super directly related to the case, but I think is a really useful teaching point. The other key thing that I wanted to cover today was one of the teaching points for the case itself, Lofgren syndrome, which this patient fits very well, seen in 5 to 10% of sarcoidosis cases, in which you've got this triad of hilar LAD, acute symmetric oligoarthritis, and erythema nodosum. And it's self-limiting. The EN goes away after a few weeks, but the joint systems can persist for a really long time. As seen in this patient, the most commonly implicated joint is the ankle, and both of these patients' ankles were implicated. And you may also see pulmonary symptoms, as we did in this patient. So that was a cool little subdiagnosis of sarcoidosis that was new to me, and I wanted to share with you all today. So to summarize, we talked about seronegative rheumatoid arthritis, which is this fascinating subtype of RA that can be hard to diagnose and manage. We talked about HLA allele predispositions to both RA and sarcoidosis and the overlap between some of these presentations. And we talked about Lofgren syndrome, which is a subtype of sarcoidosis, acute sarcoid arthritis, and that fits this patient very well. So the question that I have for you after looking at all of this information is that the more I was looking at sarcoidosis as a disease, the less sure I was about whether I'd ever be able to identify it in a patient myself, just given the spectrum of presentations that are all associated with sarcoid. So I'm wondering, when you see somebody and sarcoid shows up in your mind as part of your differential, what clues you into that?
Oh my gosh, I think that's a fascinating question. I completely agree with you. I don't really believe that sarcoidosis is a single disease. Honestly, I think that sarcoid is an aberrant reaction that the body tends to reproduce in response to very specific stimuli. So we know some things that do it, but we also know that we also just recognize that it tends to be idiopathic. And I think that's a superb question, and probably informed by the fact that we should really view sarcoidosis as a pulmonary disease with systemic manifestations. So immediately, if you're thinking sarcoid for whatever reason that brought you into it, and it's usually a multi-system disease, if there's no pulmonary findings, you should dramatically reduce the incidence of sarcoid in your mind. And so I think it's helpful to memorize and upload and understand the pulmonary findings, which is a separate talk. So I think that really, if you're thinking about sarcoid, you should ask yourself, what do the lungs look like on imaging? That's a key question. But the interesting thing is that sarcoidosis, if you don't have access to pulmonary imaging, I think there are a couple of soft clues that are apparent in your sequential evaluation. The first is really a close attention to the physical exam. And sarcoidosis tends to have a propensity for affecting things in the upper body, and it leaves an imprint on the face. And that imprint is in the form of uveitis, which the patient may have a history of. The imprint is in the form of parotid enlargement, which the patient may or may not have in front of you, but a history of it is certainly there. And then they also have a characteristic rash that's present in about 30% of patients called lupus pernio, which affects the tip of the nose and the edges of the nose. So the facial signature of sarcoidosis is prominent, but also includes a little bit of the neck. Most patients have very small cervical lymphadenopathy and maybe supraclavicular lymphadenopathy. So if you're thinking of a sarcoid, your mind goes to the chest, but kick it up a gear and go up to the neck and the face. There's often very powerful clues there. And then the laboratory clues are very, very telling. And one powerful laboratory clue is chronic hypercalcemia. And it's the key word. There's not many things that cause chronic hypercalcemia. Now you may counter and say, that's not true. It's not quite chronic hypercalcemia, and that's true. It's chronic hypercalciuria. So almost all patients with sarcoidosis will have elevated urinary calcium, and some of them will have so much hypercalciuria that the kidney no longer can handle it, and they become hypercalcemic. So many patients with sarcoidosis will have kidney stones, will have nephrogenic diabetes insipidus from the hypercalciuria. So it really is, for me, the chronicity of the syndrome is important, because acute sarcoid is TB or lymphoma until proven otherwise. And so if you have a chronic syndrome that has a pulmonary manifestations, that has a facial and neck imprint, I think that goes a long way. It is true that there are some form of sarcoidosis that present much more acutely, and those are a subset of them. Those are much harder to diagnose. but tempered by the fact that acute sarcoid tends to vanish as quickly as it came. So if you just exercise a little bit of diagnostic conservatism and say, hold on, let's see what happens in the next month or so, most of those patients will get better. So to summarize, there's some unique foreground signatures, but the time course is the most helpful one. You're not going to have lymphoma for 2 years. You're not going to have TB for 2 years. And if you happen to be the person with sarcoidosis who's developing in a very hectic, aggressive, acute manner, if there's nothing obvious as an alternate diagnosis, take your time and watch the Lofgrens melt away, watch the Heverforts melt away. But that time is very, very nerve-wracking, very, very nerve-wracking. Yeah, amazing question. Any follow-up thoughts or clarifications on that? Awesome, y'all. Well, we'll hang out live for a little bit, but thank you all for such incredible teaching. And the spectrum of liver abscesses and Klebsiella to thinking about the age-old pain of PMR and DCA to some very incredible physical exam pearls to Neisseria, gonorrhea, and the pelvic fluid to seronegative RA and Sjogren's having some genetic imprint. So much learning this week. Really, really appreciate you all. Thanks for hanging out. Let me stop the recording and then we'll chat for a little bit here.